Today's presentation is titled Holistic Approach to Pain in Long-Term Care. We're so fortunate to have with us two individuals who are passionate about today's topic. First, we have Daryl Hutton. Daryl has been with the region of Peel for Sheridan Long-Term Care since 2017. As a registered practical nurse, he started working on the front lines delivering care to patients. In 2019, he began working as a behavioral support Ontario nurse, where he gained a lot of experience working with people with dementia and learned how to best support them on their journey. In 2020, he worked for 4 months on the COVID-19 support unit, caring for residents who were tested positive with COVID-19. Currently, he is in the Butterfly Model Lead. He's a Butterfly Model Lead, Hendon Spruce Lane, a special behavioral unit, where he focuses on integrating his nursing and behavioral skills to help care for residents living in the home. We also have Jela Jekovic. She's a supervisor of care at Sheridan Villa. Jela is a registered nurse who began her journey in long-term care as a PSW, then practiced as a registered nurse after obtaining the registered nurse certificate. Before becoming the supervisor of care at Sheridan Villa in 2019, she worked in 4 different organizations as the director of nursing care. These included Schiegel Villages, People Care, Universal Care, and Responsive Group. As an experienced registered nurse, she has 21 years of expertise in both leadership and supporting nursing teams in long-term care. So without further ado, it's my pleasure to present to you our speakers, Daryl and Jela.
Good afternoon, everybody. I just wanted to thank everyone for joining us today with our presentation on the holistic approach to pain in long-term care. Just give me a moment here, guys. There we go. Okay. No more technical difficulties. Okay, so I guess I'll just start from the beginning, and I'm just going to pose the question, really. What is pain? So pain is a general term that describes uncomfortable sensations in the body. It actually stems from the activation of the nervous system. It can range from annoying to debilitating, but really, when we ask ourselves, what is pain? It's whatever the experiencing person says it is, existing wherever and whenever the person says it does. So when we're assessing for pain in someone who is cognitively impaired or just simply unable to articulate what they're feeling, there are indicators to alert us of the presence of pain. So some of the things that we do look for, we're looking for the precipitating factors, or really what's causing the pain. We're also looking for the quality of the pain, or how bad is it? We also want to try and identify the location of the pain and if it's radiating to other parts of the body. We also need to, and I stress we need to identify if that person is able to accurately describe the pain, or if there is a question around their capacity to do so, possibly due to cognitive impairment. And of course, there's timing. Does this pain occur at certain times of the day? Does it occur during certain activities? Or is it always present? So if you'll allow me to take a moment to read from this slide. So I'm going to read to you guys a couple of myths or facts. And if you could just take this opportunity to consider some of these statements and try to determine if they are true or not. So, myth or facts? Pain is a normal part of aging. Cognitively impaired people do not experience pain. It is best to save the stronger pain relievers until the very end. Patients often develop tolerance to pain medications like morphine. Once you start pain medicines, you will always have to increase the dose. To get good pain relief, you have to take injections. Pain medications always lead to addiction. Withdrawal is always a problem with pain medications. Enduring pain and suffering can enhance one's character. Once you start taking opioids, the end is always near. And of course, people have to be in a hospital to receive effective pain management. So when we're screening for pain in long-term care, we ask ourselves, who can screen for pain? Well, the answer is simply anyone can. Anyone can screen for pain. The nurses can screen, our support staff can screen, and family members can also screen for pain. So it is important, once the pain has been identified, that we let our register staff know immediately. And it's also imperative that we definitely do not wait until the end of the shift. The proper management of pain hinges on timely identification and reporting. For this process to be effective, it is imperative that staff is educated and trained. The communication between all disciplines are key factors in proper pain management. So to achieve success in pain best practice guidelines, the inclusion of the entire multidisciplinary team is paramount. So when we're doing the assessment, or once the pain has been identified, the register staff will then proceed with what we have as the pain assessment. So I just wanted to make a note here to everybody. Every single positive pain screening should result in a pain assessment. So essentially, in long-term care, we use two types of assessments. We have the numerical assessment, which with this one, it will only work if the person asked is able to rate their pain on a scale of 1 to 10. So 1 being very mild and 10 being extremely painful. And then of course we have the pain add, which is pain in advanced dementia. So this scale is utilized for those that are cognitively impaired or just simply unable to articulate their pain. This one is also scored out of a scale of 10. However, the nurse or the assessor will go through a predetermined set of physical characteristics to achieve that score. So some of the characteristics that we're looking for would be breathing. So is the breathing noisy? Is it labored? We also look at vocalizations. Is there moaning or repeated calling out? We'll also try to note their facial expressions. Are they smiling? Are they inexpressive? Are they sad, frightened? Do we note a grimace? Certainly we're going to look at body language. Do they appear to be relaxed? Are they tense? Do we note that they're distressed? Are they rigid? Or do we see any wincing or grimacing when we try to do activities with them? And of course, the last one we would look for is, are they consolable? So can we reassure them with our voice, our touch, or are they just simply inconsolable? So each category in this scale will get a score out of 2 points, and that will equate to a final score of 10. So once the pain has been scored, this will then determine what interventions will follow. So the interventions can include pharmacological or non-pharmacological interventions. But after the interventions that will be utilized have been identified, the nurse must evaluate after 1 hour and determine the effectiveness by using a proper reassessment tool. So if the interventions have been effective, then the nurse will continue screening. However, if the intervention was ineffective, then a reevaluation must occur, and new interventions must be determined through collaboration with the physician and fellow team members. So on the next slide, I want to share with you guys an algorithm that we share with our staff, and it really is to help guide them through this journey or this process of identifying and managing pain. So as I said just before, the first thing we do is we screen. If it is identified, we go into our software system, which is called Point-Click Care, and we'll open up a pain screen assessment. Once we complete this assessment in our software program, and this will also include that numerical scale that I just identified, we will then determine what our next steps are. So will we administer pain medication? Do we have a PRN available, so an as-needed medication? Or can we utilize a medical directive, a set of predetermined orders that the physician has provided? And of course, if it's appropriate, we'll certainly look to utilize some of the non-pharmacological interventions. So as mentioned earlier, after 1 hour, we'll continue with the reassessment. And through this reassessment, we'll be able to determine if the intervention was effective or not effective. So we go down 2 avenues now. So if it was effective, then we continue with the pain screening every shift indefinitely. If the intervention was not effective, we will reassess the routine pain meds and then determine which additional interventions that we need to follow up on. And I want to come back to everyone and stress that these interventions are a collaboration between the multidisciplinary team. No one person will be, deciding what the next steps are. So I want to show you everyone this graph. It's a very simple graph. So it's really just asking us how we're doing. So when I look at the orange line, that would represent the provincial average. And then when I turn to the blue line, that's going to be our average at the region of Peel. So this slide is just simply showing us how many people have had pain experiences whilst in long-term care. So you can see the provincial average is hovering at around 5%. In the third quarter of 2020, it seemed to have dipped quite a bit and trending evenly after that. So for us, the blue line, we're looking at our representation of the people that have pain. So right, according to this graph, from the first quarter of 2019 right up until the fourth quarter, we're pretty well below the provincial average. So that leads us into the next slide. So these people that are experiencing the pain, what's the percentage of it worsening? So again, the orange line being provincial, blue being ours. You can see from this graph quite simply that I'm happy to say we are well below the provincial average. So from these graphs, it shows that our implementation of our pain program and assessments have been effective. So I will move forward to the outcome slide. So we are always looking for outcomes and how we can best manage this pain. I want to share with everyone that sorry, 1 second here, guys. Yep. So why do we screen for pain and why do we try to manage it? Essentially, right at its core, we're trying to optimize a person's quality of life, where they otherwise would not be able to tell us or describe their discomfort. So managing pain and ultimately palliating those that are living in long-term care does have a significant impact on a person's quality of life. Oftentimes, we will see someone that's exhibiting expressive and/or responsive behaviors that could come in the form of physical expressions or verbal expressions. So while we screen for pain, we have to keep in mind that this could be the precipitating factor as to why we're seeing some of these expressions. So through this process, and by implementing the non-pharmacological and pharmacological interventions to manage pain, we have seen a decrease in responsive behaviors. And we're also seeing a decrease in psychotropic medications. So if pain is properly identified, we can manage pain through analgesics as opposed to psychotropics. And ultimately, and I stress ultimately, the reason why we do this is to achieve a better quality of life for those people that are living in the long-term care sector. So after we go through all this and we're looking at next steps, it's important that this information is clearly communicated to the rest of the team. So, we ask ourselves, and I'm sure you guys are asking, how do we do that? So we do that through documentation. And where do we do that? So in addition to this documentation, I would like to add that there are numerous verbal reports that take place during shift exchange, one-to-one exchanges. I know the nurses are talking to each other, sharing information constantly throughout their day, but we have to consider for those that weren't present during the assessment. So where do we document? As I mentioned earlier, we use a system called point-click care. And within that system, we are able to document in several tabs, one of them being through the pain assessment tab. We also have a care plan that is visible to all register staff and support staff, so they are able to see the latest interventions and the latest assessments. And of course, we have a RISE specialist here that will document those findings in our MDS sections. So all the register staff does have access to this information, and it is a continuous cycle of information being shared through the multidisciplinary team. So before I finish off, I just want to say in closing to everybody, through the proper identification and management of pain and long-term care, we are able to reduce responsive behaviors, as well as decrease the use of psychotropic medications. And ultimately, I can't say this enough, I think I have said it a few times, but ultimately, we are here to enhance the quality of life of those that are experiencing pain while living in long-term care. So thank you, everybody, for joining me on that one. I'd like to open it up now to some questions, if anyone has any.
Thank you so much, Daryl and Yella, for that excellent presentation and for giving us a pragmatic and systematic overview of the implementation of the pain BPG in your long-term care home. So we do have some questions here. We have one from Jacqueline. She is saying, what is your source for your provincial data?
What is my source for provincial data? That is a good question. You know what? I actually don't, it's not a good start, but I don't have the answer to that. But I can certainly, whatever I don't know at this time, I would be happy to get back to people and provide that question. So for me, that data is represented on our software system here. So as far as the source goes, and that's a really good question, I actually am not entirely sure, but I am writing it down, and I would be happy to get back to whoever asked that question.
Okay, perfect. So Jacqueline will get back to you, or we will email everyone in regard to that follow-up question. Thank you.
Thank you. That was a good one.
You're welcome. We do have a number of other questions that are coming in. One of them is it possible to decipher someone's pain level with advanced dementia?
Yeah, that's also an excellent question. So yes, I believe it is certainly possible. So, I mean, as I had mentioned in the presentation, because people would not be able to articulate, obviously, their feelings or their emotions, especially in the advanced stage of dementia, we do rely on kind of identifying those physical characteristics. So when I say that, I mean, like I had mentioned, we're looking for body language, right? We're looking for facial expressions. We're listening to how they might react during certain activities. And when I say activities, I mean, you know, the activities of daily living. So if when we're providing care, if we're noticing recoiling or wincing or vocalizations that are negative, I mean, these would all be indicators of pain. I do recognize the difficulty of diagnosing someone with pain in advanced dementia, but I do feel that we are well equipped with the tools at our disposal.
Okay, that's excellent. So you described how it is to assess pain level, and then perhaps related to that, how is pain able to be assessed in terms of, I guess, management? You say that there's ongoing assessment indefinitely, and how do you do that specifically for individuals who are unable to articulate their level of pain?
Right, so once the pain has been identified, if it has in fact been identified, and of course, you know, we would go through our interventions through discussion with the team, the family, everyone's involved. So to have it recurring or to have it to continue on. So in our point-click care system, our nurses that come in to say at the start of their shift, they actually get a visual prompt to assess that pain. And essentially, they can't, you know, we make it kind of foolproof. They're not able to really leave until they've done that assessment. I mean, the program won't close for them. So they are prompted to do it. So it takes out all the guesswork. So if there's a new diagnosis of pain that someone didn't have it before, it would show up on their profile at the beginning of their shift, and they would have to essentially sign off on it that they've done that assessment and that they've actually done the interventions.
That's excellent. So the point of care prompt, just to be able to ensure that something as essential as an assessment and a follow-up is consistently done in practice. So
Correct. Yeah.
excellent. Thank you, Daryl. We do have some other questions coming through. It says, and this is after the assessment, how do you know how to proceed and in what order you want to complete the assessments?
Well, yeah, so that's another great question. So definitely, again, we want to take out any guesswork, right? I mean, we want people to be able to do this seamlessly. So we do have a pathway, which I did share in a previous slide. And essentially that pathway walks you through the process. And when you come to, say, a crossroad where you're looking at maybe effective or ineffective, the pathway then splits, and it will take you down separate avenues, if you will, to guide you to the next step. So it's very well laid out, and again, it doesn't leave like a lot of guesswork, and that's the intention, right? So
Mhm.
the person can walk in at the beginning of their shift having no information, and then they can follow this pathway and be able to successfully navigate through it.
Okay, thank you so much. There is another question here from Nithu. For someone who uses all their regular narcotics and PRN narcotics and still in pain, what would you suggest as the next step?
Yeah, that's a great question. And we do see that, right? I mean, sometimes the current interventions are not effective. So for me, and again, I'm going to say that this is a collaborative. So it would never be the nurse's decision what to do next. So in my experience, when I am noting that pain is not managed, um, definitely my first point of contact would be the physician. So I will contact the physician. I will explain to them my findings. I might even make recommendations, but as a nurse, obviously I'm not a prescriber. But I will, because at the end of the day, I do feel like I'm here with a little more presence than the physician is. So he might appreciate the recommendation, but when I explain to him what's happening, I will go through everything I've tried. I'll explain what they're on, the frequency, the dose, the type of medication. And then again, I might make a recommendation having known that resident maybe really well, but ultimately then the physician might make a new prescription or add an increase a dose perhaps. But if I can't get a hold of the physician, then my next step would be to discuss with the team, and that would include everybody, the nurses, even the support staff. The supervisors are always a good way to go. So it's really about effective communication, and I do find also that talking to the families, they're going to have that medical history that maybe we don't have at our fingertips. So you're really just trying to gather as much information as possible so you can move forward in the most appropriate way.
Yeah, that makes good sense. A comprehensive pain assessment so that you are able to accurately manage the pain. And I do really appreciate your interprofessional approach to pain management in residence.
Thank you.
There is also another question here. Do you know of other pain scales educational tools to use for cognitively intact residents who consistently report severe pain levels, even though their body language, facial expressions, and ability to perform daily activities does not match the reported level of pain?
That's a tricky question. So there definitely are other pain scales out there. And full disclosure, I don't feel all that prepared to go through those scales with everybody. I'm most familiar with the ones that we're using here, but I would definitely recommend, because that's a great question. There are several scales to be utilized. So definitely a quick Google search would help you kind of find those answers. But I wouldn't say one is more effective than the other. We're just using the ones here as mandated, but certainly, that's worth exploration because it's not a perfect science. There's going to be a lot of subjectivity to what I see versus what my coworker sees. So exploring the different ways to assess and determine pain outcomes is highly recommended for sure. But that was a really good question. Sorry, I don't have a more comprehensive answer.
No, that's okay. I mean, as you said, pain is subjective. And I was wondering, have you looked into cultural considerations in terms of the expression of pain? I'm just thinking about, different people's expressions of pain.
Certainly that's considered, absolutely. I mean, I find, and I don't take this for granted, but I find that the signs of pain tend to be fairly universal. And although there is a certain amount of subjectivity to it, when you identify it, not always, but sometimes it does come across as rather obvious. I can give you an example. Someone may not present with pain in their everyday activities, but the second you begin to interact with them, and I'm thinking some more of the physical interactions like providing care or even just doing an activity with them. And I had mentioned that I am supporting the butterfly model. So, we do work with a lot of non-pharmacological types of interactions. And, some of that can be, tactile. So you might note that in someone's everyday living, they don't present with pain, but the second they start moving or you start moving them, it does seem to be most of the time fairly obvious that there's some discomfort or pain present, in fact.
Okay, yeah, that makes good sense. Thank you,
Mhm.
Daryl. There is a couple questions actually from Steffi. The first one is, how do you overcome families who intervene in a negative way? So let's say a resident says they have pain and the family states they don't want the res to have PRNs. Do you have any recommendations on how to manage a situation like that?
I can certainly try. I will tell you that is common. I think in general, there's an adversity to people being over medicated. So my response to that, I mean, there's no one clear avenue. What you're going to find, your best approach, is that interdisciplinary approach. So what I do personally, and I've had success with this, is I look to provide them education, kind of like the one today on screening for pain, managing pain, identifying pain. And I really want to educate that person on what it may be like for somebody living in constant pain. But that's not something that I would do on my own. So, I mean, certainly I would open the conversation, but for those powers of attorney or family members that have a strong adversity to not just pain management, but medications in general, I find that, the more knowledge you're able to spread to them, the better. So I personally then would call what we would have is a care conference, we call it. And at which point that's a scheduled meeting with all members of the team. And in those situations, especially when it's medication driven, it's imperative to have a physician there to support you because they're going to have that skill set and that knowledge that maybe we didn't get in nursing school. But it's an interdisciplinary approach, and you just need to really have the entire team to convey this information. And it is absolutely like, I keep using the word imperative, but it is imperative that everyone's on the same page. And you're not always going to be successful, but then all you can do at that point is gather the evidence and present it to them in a timely manner, because ultimately, quality of life suffers when somebody is living in day-to-day pain, and it's our responsibility as clinicians to properly convey that information to the families and have them understand the importance of the management of these symptoms.
Excellent. Thank you so much, Daryl. And can you also speak to the butterfly model that you just mentioned?
That could be many hours of discussion. Where to start? I mean, I can definitely scratch the surface, but honestly, it's a very involved model in a sense that we're trying to change a culture in long-term care, and it's not easy, and it's definitely not something that will happen overnight or even in a year. But essentially, the butterfly model it's a model based on person-centered care. So when somebody comes into long-term care, it's not a facility, it's not a hospital, it's their home, and it is their home because they're living here. And oftentimes, more often than not, unfortunately, this is their last stop. So we recognize that their time here is going to be indefinite, and they're living here, right, for the long term. So we really try to focus on the person-centeredness and the individualistic interventions that we could provide to each and every person. It's really about getting to know the people that live here and really tailoring specific interventions. And when I say interventions, I don't just mean medical, I mean more so the non-pharmacological. So who that person is before they came here, who they are now, how to engage them, how to find a way to work with them that suits their needs best. And my experience is when you it takes a little bit of extra research to know these people, but I mean, we're nurses and we're in this profession for a reason. And I sincerely believe that most nurses, if not all, have a reasonable amount of compassion for their work. So if you just take a little bit of extra time to get to know that person and understand what their individual needs are, I have personally seen a decrease in these responsive behaviors, as well as some of the more adverse medications or the more controversial medications, such as antipsychotics and psychotropics. And that is part of what I do at Sheridan Villa, is try to reduce these things and have a more positive outcome. But I feel like to give the butterfly model complete justice, I would need a lot more time.
No, it sounds fantastic. The philosophy of
Yeah.
person and family-centered care, and being able to
Absolutely.
provide that holistic care, with pain, with dementia, with delirium, with depression, or whatever it may be. It's centered on the patient and his or her quality of life. So thank you.
Absolutely. You're very welcome. Thank you.
You're welcome. I do have two other questions here.
Sure.
Did you say that for your pain management program, that once you notice or screen for pain, the registered staff should always perform a pain assessment under the assessment tab in PCC? So I'm assuming point click care.
Correct. Yeah, that is pretty much verbatim the process. Yep, absolutely.
There you go. Okay.
Yeah, absolutely. Yeah. So I mean, not to be redundant, but yeah. So I do want to say though, once pain is identified, it cannot be stressed enough that it has to be assessed immediately. So you can't wait a half hour or an hour, or I mean, obviously not to the end of your shift. The outcomes are at the end of the day, it could actually make things a lot harder for you. But I mean, on a more kind of holistic approach, we really want to manage that pain in that person, because it's just going to have negative outcomes for them. And that could come in the form of, again, physical or verbal type responses, or it could come in, I mean, I think just simply for me, the fact that somebody is in pain, I empathize. And I think if I was in pain, I mean, on a much smaller scale, if I have a headache, I don't wait an hour to take analgesics. Like, I do it immediately. And so we really, look at it from our point of view, and we try to empathize. And I think, what would I want if I was in pain? So you need to address that in the most timely manner possible.
Mm-hmm. That makes good sense. Is that indicated at all in the algorithm, the sort of the timing of the screening to that of discussion and intervention? Just you're talking about.
Yeah, you know what? I don't have it in front of me, but I don't believe that actually it is. Now, I don't like to leave a lot of things to I guess common sense, but that's a really good point. And I don't believe that it is actually embedded in that algorithm, but the algorithm's not in stone, so it is subject to change. So, maybe that's something that should be put right in there, just so there is, again, taking away all that guesswork. And that way, you're ensuring the best possible outcomes for those that are experiencing pain.
Mm-hmm. Mm-hmm. Okay, thank you. More questions, Daryl?
Okay.
So George is asking, does your facility have access to an NP through the NP outreach program, and do they play a role in treating pain?
Yeah, that's a great question. So I can speak for the region of Peel, and more specifically Sheridan Villa. We do have a plethora of resources here, and the NP is one of them. So the NP is a phone call away, and typically if it's something like pain management, something that can be identified verbally over the phone, sometimes we can actually get a verbal order right over the phone, and that way you're minimizing that amount of time that person is in pain. Now, if it requires an NP visit, my experience is if we call the NP, they are coming that day and oftentimes within the hour. So we are very lucky to have such expedient resources. But yeah, we do have an NP. We have a couple actually that are utilized here.
Oh, excellent. So when you speak about the interprofessional team, it's the RN, it's NP, it's physician. Who else were you listing as?
Well, yeah, for sure. I mean, I guess it depends on your identification of the pain, but you might want to, we have physiotherapists on site. We have RPNs and RNs as mentioned. Of course, we have an MD. We also have a PRC, so that's a psychogeriatric resource consultant. That's a mouthful, but they're also a resource for us, and their name, the C for consultant, is we can call them and consult anytime. And I also want to share that we do have another specific resource. We have a palliative and pain consultant that is also just a phone call away, and they do visits here monthly. Now that was pre-COVID, so we're trying to get them back in the building, but we had a monthly visit from them, and we would have cases prepared for them, and we would review, and then we would get suggestions.
Excellent. Thank you. Additional questions. One of them is, how do you manage pain after someone had an unwitnessed fall and is on a head injury routine where we hold antipsychotics? PRN Tylenol based on medical direction is insufficient. What do you recommend in that moment to help deal with behaviors associated with dementia?
So yeah, that's a good question. And I just want to back up for a second. So we, in this scenario, we have identified the triggers as pain. Is that what we're thinking? If that's the case, and we recognize that, yeah, your Tylenols and Advils and what have you, your NSAIDs or analgesics aren't working, again, you're going to rely heavily on the resources at your disposal. And it is 24 hours. I mean, we have a 24-hour physician. So in my experience, and that has happened to me, you do your reassessment after the initial, and you realize that it's not being managed. So for me, I will immediately get on the phone with the physician, and you do a bit of a situational exchange of information, if you will. You describe what you're seeing. You're going to identify that you're seeing or that you believe that it's unmanaged pain. At that point, the physician, with their wealth of information and education, would be able to either increase a dose or suggest a new dose of something, and opioids is always an option, but it's not the first line of defense. So if the pain's unmanaged, then certainly we know that we could go that route. But again, it takes quite a bit to get there, and has to be quite a bit of, not quite a bit, but you really have to identify that the pain is not being managed. So there definitely are avenues to go down, but your main resource at that point is going to be the physician.
Okay. And I think this question is related to Steffi's question, but do we have to hold antipsychotics in head routine injuries?
No, that's not true. So antipsychotics don't need to stop for that one. And Yella actually had just chimed in, and so what we would do is hold the anticoagulants. So if there is a blood thinner, whether it's just an aspirin or something like warfarin or heparin, certainly if it was an unwitnessed fall or even witnessed, and we know that there is a head injury, those medications would be held, and that would be at the clinical decision of the nurse. But you would have to follow up with the physician, report it, and get further direction. But to answer the question around antipsychotics, typically they're not held.
Okay, thank you. And we do have time for one more question, and it's from Naomi. She says, how do you deal, and this is a big question, how do you deal with abuse, narcotics for pain and addiction?
Abuse. That's a tough question, honestly. I guess, first of all, you have to identify that there is, in fact, abuse, right? Um, I think there's going to be, and of course it happens, but there's going to be some difficulty um, for someone to abuse those types of medications in long-term care because, the people that are living here don't typically have direct access to their medication. So their medication, whether it's opiates or benzodiazepines or whatever controlled medication it is under constant review, and it is delivered by the nurse. So there's a certain amount of control on how often they get it and what the doses are. Of course, they can always request more, but that comes under review for sure. But certainly I have seen it, or I believe I have seen it. And then you just have to table that discussion on a bigger scale with the entire team for sure.
Okay, thank you so much. So it looks like that is all for the questions, and want to thank you, Daryl and Yella, for that excellent presentation and for a very engaging discussion today. So thank you to the participants for asking a lot of those questions. At this time, we want to be able to bring the webinar to the end, but just wanted to let you know that you will receive a link to the online survey to evaluate today's presentation. So please let us know how today went and also any future topics in regard to yourself as a champion and what you'd like to be able to hear. Once you fill out the evaluation form, you will be able to receive your certificate of attendance. Just to let you know, this work is funded by the Government of Ontario, and thank you again for joining us today, and thank you everyone. Have a great afternoon. Bye-bye.
And bye-bye. I want to thank everyone for such an engaging conversation. Thanks again, everybody. Have a great day.
Thank you, Daryl.
Wow.